Hello again. Now we start the last session of the day. Gastrointestinal manifestation in the light chain amyloidosis. And I invite Dr. Speranta Iacob, please.
Thank you very much for the opportunity to be again in this conference. It's a pleasure always to collaborate with Professor Coriu and my colleagues from hematology. And I will speak about amyloidosis and the liver, a silent partnership with life-threatening consequences in quite a lot of patients. So why does the liver matters in this disease? Because it's multisystemic, as we already know, but very often it's silent until the liver speaks, and this liver involvement occurs in about 15 to 30% of cases. Usually is non-specific clinical presentation with fatigue, weight loss, and peripheral edema. And liver involvement is usually subtle at the beginning, often overlooked by clinicians and thus underdiagnosed. Often the patients have abnormal liver function tests, but these are rather frequently misinterpreted or wrongly attributed to other common hepatic conditions like MASLD or cholestatic liver diseases. And due to the fact that this diagnosis is not recognized early, the prognosis is often not good. I don't know where to stay to move the. Usually, what do we observe in clinical practice? A disproportionate hepatomegaly with relatively well-preserved liver synthetic function at the beginning, at least, with mild cholestatic liver enzyme abnormalities in a patient that does not have usually the classical risk factors for chronic liver diseases. We have often elevated liver stiffness values on transient or shear wave elastography, but without typical ultrasound features of advanced chronic liver disease. And often we have concurrent cardiac symptoms, proteinuria, or peripheral neuropathy. So hepatomegaly is often one of the most frequent clinical features that we discover, present in up to 70% of patients with IL amyloidosis, often with mild elevation of liver enzymes, usually increased LAP and GGT, significantly disproportionate compared to the increase of aminotransferases. Usually this cholestatic pattern is subtle, and at the beginning the gastroenterologist may misinterpret them as biliary obstruction or, as I already mentioned, cholestatic primary liver cholangitis or sclerosing cholangitis, or maybe even considered as drug-induced liver injury. And there are a lot of cases that say that maybe due to statins, because a lot of patients have cholestasis and increased cholesterol levels, and they at the beginning receive statins, and a lot of colleagues can attribute this to statins liver injury, and in fact maybe amyloidosis. At the beginning, usually the bilirubin is not high elevated, but INR can be modified, and this again can mimic advanced liver disease or ACLF, but we should notice the monoclonal pattern of gammopathy, and as I already mentioned, high cholesterol levels instead of low cholesterol levels like in advanced liver diseases. And again, the non-specific symptoms that I already mentioned, and edema due to hypoalbuminemia, that it's again can be mistakenly attributed to nutritional deficiencies of liver cirrhosis. I don't know why. These are the anatomopathologic findings, and these are pictures from the collection of Professor Becanu, and these are a typical, that we all know, Congo red staining, positive. We do not perform liver biopsy very often. And why do we don't do this? Because there is a high risk of bleeding, because there are often may occur unpredictable and severe bleeding after liver biopsy. There are a lot of cases that document fetal hemoperitoneum after liver biopsy, and then we usually prefer other sites for biopsy, like fat pad aspiration, salivary gland biopsy, or rectal biopsies. So in amyloidosis, tissue is the issue, but we usually do not perform liver biopsy because it's high risk and does not perform always the diagnosis. So we prioritize for being more easy and safer fat pad biopsies, salivary glands, or rectal biopsies. These are abdominal ultrasound features that can again help us to differentiate liver amyloidosis compared to liver cirrhosis. The characteristics of amyloidosis are usually a liver that appears diffusely enlarged but homogeneous, with typical clinical signs of portal hypertension, although they have sometimes splenomegaly, but they don't have dilated portal veins. So signs of other signs of portal hypertension. Instead, in liver cirrhosis, we have the characteristic nodular liver surface and heterogeneous echostructure, and for sure, splenomegaly, ascites, or portal vein dilation. Ascites can occur also in amyloidosis. Again, there are features that overlap, but there are again other things that for sure can differentiate the two diseases. Liver elastography is also a very useful diagnostic tool that we can use in amyloidosis, both transient elastography and shear wave elastography. We have a very high liver stiffness due to amyloid deposits and not from fibrosis. Again, totally different mechanism compared to liver cirrhosis, and usually it's significantly higher values compared to liver cirrhosis. So liver stiffness can help us and usually correlate with the degree of amyloid infiltration, and thereby it can help us in clinical assessment of these patients with subtle changes and without any need of liver biopsy in this regard for diagnosis. In the last years, spleen elastography is again another tool that can help us differentiate between liver cirrhosis and amyloidosis. Splenic involvement is often also involved in amyloidosis, and this can be seen in up to 40% of patients. Splenomegaly is possible to occur, but not usually as big as in liver cirrhosis, and the liver stiffness, the spleen stiffness is can help us differentiate between amyloidosis and portal hypertension. Here the cutoffs are not so well established like in assessment of liver stiffness, as we will see. And probably this, in my view, is a field to investigate further and to establish cutoffs in this regard. I just wanted to briefly mention the cardiac amyloidosis that can have also impact on the liver and also can increase the liver stiffness. Further in cases that are complicated with cardiac amyloidosis, and again here it's not very easy to differentiate between hepatic congestion or amyloid infiltration of the liver, and again can be challenge in diagnosing these patients, and here is our art in diagnosis and putting together all these features. Again, this is just a table to summarize what I already said about ultrasound and liver and spleen stiffness, and also biochemical pattern to differentiate between amyloidosis and liver cirrhosis. I just wanted to mention this very new study about diagnostic performance of liver stiffness in amyloidosis that clearly showed that a cutoff of 14.4 kilopascal yielded a diagnosis of liver amyloidosis with a specificity of 74%, but in our ROC that it's just 0.7. This was compared to liver scintigraphy that had a higher specificity. However, combining liver stiffness over 14.4 with the high alkaline phosphatase improved the sensitivity to 68% and a rather good specificity for diagnosis of liver involvement in amyloidosis. So once again here, liver stiffness over 14.4 is a promising non-invasive marker for liver involvement in amyloidosis. I want to mention that compared to liver cirrhosis in this study, we have around the same cutoffs, 12.5 to 14 to diagnose liver cirrhosis in clinical practice. But I will further show you our study done together with Professor Corriu and his team, and you'll see that in our experience the cutoffs are considerably higher. Here is just to mention that magnetic resonance elastography can be also used for diagnosing and non-invasive imaging of liver stiffness and for establishing the diagnosis of liver involvement and also spleen involvement in amyloidosis. And I mentioned here two studies that confirm that MR elastography is a very good quantitative tool to assess liver involvement in amyloidosis. And just in this picture from this article, it's the liver stiffness is 18 in MR elastography, and in liver cirrhosis, in usually clinical practice, we have for diagnosis of liver cirrhosis a liver stiffness of 4 to 5, and spleen stiffness in MR elastography in amyloidosis is 16, and in liver cirrhosis in clinical practice is around 6 to 7, and this implies severe portal hypertension. So here again, the differences between liver cirrhosis and amyloidosis is significant. Here is our experience. It's already rather old, I will say. It's 101 patients evaluated in hematology clinic under the coordination of Professor Corriu and my colleagues Sorina and Andrea, and all these patients underwent fibroscan. I just mentioned that most of them had kidney involvement, followed by heart amyloidosis, liver amyloidosis in over 50% of cases, and also nervous, autonomic nervous system involvement. And the cutoffs that we obtained for diagnosis liver involvement was over 21.5 kilopascal. If the patient had also cardiac involvement, and over 17.6 kilopascal, so significantly higher compared to liver cirrhosis in clinical practice in patients that had just liver involvement without cardiac involvement, with a rather high specificity for diagnosis. And when patients had multiple organ involvement, the liver stiffness was even higher, over 32.5 kilopascal. We've noticed a significant difference between patients with liver involvement and the ones without liver involvement. And when we compared again in other terms of other clinical parameters, patients with hepatic involvement of amyloidosis and without, we've noticed that besides the significantly increased liver stiffness, the patients had also increased GGT, alkaline phosphatase, SAT, bilirubin, also significantly decreased factor 10, and a significantly higher MELD sodium score compared to patients without hepatic involvement. In the multivariate analysis, we identified as predictors of mortality, hepatic involvement of amyloidosis, orthostatic hypotension, and a lack of treatment with bortezomib. As I mentioned, it's rather old, this cohort, so we didn't evaluate the impact of daratumumab on the survival of these patients. So in conclusion, the FibroScan is a reliable, non-invasive tool in our clinical practice for diagnosing liver involvement in amyloidosis and can provide important prognostic information also, and supports, again, this study, a multi-systemic, multidisciplinary approach to amyloidosis management, and we didn't need liver biopsy in these patients. I would just want to mention other prognostic markers, especially the MELD score that we use for evaluating prognosis in patients with liver cirrhosis. This MELD score can be also used for patients with amyloidosis. It also takes into account not just liver involvement but also kidney involvement, because comprises in the score we need to use and to calculate based on creatinine, bilirubin, and INR. And the patients in this study that had a MELD score over 12, that for liver cirrhosis not rather high, we transplant patients and we include them on the waiting list with liver in case of patients with liver cirrhosis, even only they have MELD scores over 15. But in patients with amyloidosis, a MELD score over 12 led to a significantly lower overall survival compared to patients with a MELD scores less than 12. So this MELD score, together with an anti-pro-BNP, is another well-established biomarker. Then both can be used to assess the prognostic impact of liver involvement. This because patients that have both cardiac and liver for sure have a worse prognosis. And I want just to mention, because the case will follow, and we, as gastroenterologists, I must say that we're a little bit astonished that the patients do not have, the patients that my colleague will present do not have cardiac involvement. What are the mechanisms behind this elevated anti-pro-BNP in patients with liver involvement but without cardiac infiltration? The reduced hepatic clearance, the hemodynamic changes from massive hepatomegaly, and early or subclinical cardiac involvement that probably will occur in the future. I want to briefly mention that nutrition, in my opinion, is a key of key importance in management of these patients, because by itself it exerts his own adverse effect and can be malnutrition diagnosis in patients that have amyloidosis with both hepatic and gastrointestinal involvement predicts mortality, and nutritional counseling significantly improves outcome, as it's seen in this rather old paper. But for sure, nutritional status is a critical independent prognostic factor in amyloidosis and should be integrated into standard of care from time of diagnosis, especially the patients have from the beginning GI or hepatic amyloid deposits, because these are more prone to weight loss and nutrient malabsorption, and thus with, again, significantly lower survival and quality of life of these patients. I just wanted to briefly mention the role of liver transplantation in AL amyloidosis. Unlike hereditary amyloidosis, liver transplantation is not a standard therapy. It can be done only as a rescue option in progressive hepatic failure, and this is because the liver, as we all know, is not the source of amyloidogenic proteins like in TTR amyloidosis, and transplantation does not address the underlying plasma cell dyscrasia. And again, despite this, liver transplantation can have also a lot of risks, and it's can the progression of amyloidosis can go further in extrahepatic organs, so then survival is not really impacted by liver transplantation. Can occur graft recurrence. Mortality is rather high. There are very small reports and number of patients that were transplanted. At the 1 year survival rate is from 33. The maximum that I could find was 50%, but at 5 years is very, very low, and thus does not justify the liver transplant procedure by itself, given the fact that chemotherapy dependence is also important and can be and is required even after liver transplantation, and when the patient is double immunosuppressed, and also due to ethical and practical challenges due to the organ scarcity. However, I want to mention this article that I found published last year about the first reported heart, liver, kidney transplant for systemic amyloidosis, utilizing these new perfusion techniques from a donation after circulatory death donors. In Romania, it's not possible yet to have these kind of donors, but in Western Europe, more than 50%, at least in Netherlands or UK or Spain or France, are this type of donors, and with the so the number of donors increased a lot due to this kind of donation. So in this just one case with multiple transplants, the outcome was successful at 8 months with preserved graft function across all 3 organs, and this just proved that these new techniques of machine perfusion and this type of donors that can be successfully used also in patients with rather poor prognosis otherwise, and then maybe in future we can transform these multi-organ transplant paradigms. And again, the multidisciplinary collaboration is critical in these kind of patients. I just want to mention this patient that it's rather just one slide. Professor Coriu knows him very well, also Andrea, because it's a patient that developed de novo amyloidosis after transplant for ACV liver cirrhosis. After 12 years since transplantation, we diagnosed him with amyloidosis that he just had neurological, peripheral, and autonomous nervous involvement. But I just want to mention, similar to previous case, that this patient had orthostatic hypotension at least 3 or 4 years before diagnosis of amyloidosis, and I must admit that we started to look for this disease because he had cardiac involvement, and we believe also liver involvement, although he had ascites, probably due to cardiac decompensation, and we thought that this may be a cause, but finally just, as I mentioned, just the nervous system was in fact affected, and he died just due to cardiac insufficiency and age. So I think we also should look for this kind of diseases after transplantation, and maybe screening is required in old patients, because at least in Western Europe, again, a lot of patients are very old and they are transplanted when they are very old due to other diseases, but probably in this due long age they can develop also monoclonal gammapathies that should be diagnosed in time. So in conclusion, what can we consider as red flags, and in colleagues, gastroenterology colleagues that maybe encounter a patient that can have amyloidosis. So unexplained phosphatase elevation should prompt amyloidosis workup at least in a patient with hepatomegaly and with monoclonal gammopathy. Also a very rapid weight loss and increased phosphatase alkaline, again a strong indicator of hepatic amyloid infiltration. And as I already mentioned, a lot of patients came to us with ascites but without cirrhosis, and this is maybe the most typical patient that we should look for amyloidosis and do the differential diagnosis. And again, early diagnosis and hematologic controls are critical in these kind of patients. Liver involvement worsens prognosis, so we should act fast and not delay the diagnosis, and multidisciplinary care improves for sure the overall survival of these patients. So once again, multidisciplinarity is not just a strategy, it is a necessity, and each specialty contributes a vital threat in waiving a complete diagnosis and therapeutic harmony in these type of patients. And in just like this, we can offer our patients the timely, tailored care that they deserve. Thank you very much for your attention. And I invite my colleague to present our case together in our clinic and to discuss.
Bună ziua! Vă mulțumesc mult pentru invitație, domnului profesor și întregii echipe, și pentru colaborare. Vă voi prezenta cazul unui pacient de sex masculin în vârstă de 67 de ani, nefumător, neconsumator de alcool, cu antecedente personale patologice de hipertensiune arterială. Istoria lui începe în februarie 2018, când este decelat cu hepatomegalie într-un centru de gastroenterologie, iar un minim de investigații nu sugerează niciun diagnostic de boală hepatică. De asemenea, se decelează poliglobulie cu JAK2 negativ și biopsie medulară în limitele vârstei și proteinurie de rang nefrotic, pentru care este îndrumat într-un centru de nefrologie. Se inițiază în centrul de nefrologie metilprednisolon 500 mg pe zi și ciclofosfamid 800 mg timp de 3 zile. Se efectuează de asemenea biopsie renală, care decelează depozite de amiloid moderat pozitive pentru lanț lambda. Iar în aprilie 2018 se stabilește diagnosticul de amiloidoză renală cu boală renală cronică rapid progresivă, se inițiază hemodializă, 5 ședințe și dexametazonă intramuscular. În aprilie 2018, pacientul este admis în Institutul Clinic Fundeni, în secția de hematologie. La examenul clinic se constată un pacient cu stare generală bună, afebril, dar cu halenă uremică, tegumente și mucoase normal colorate, fără adenopatii palpabile, fără hipotensiune ortostatică, dar cu hepatomegalie, cu marginea inferioară la 7 cm de rebordul costal, splina nepalpabilă, o diureză păstrată de 1800 de ml pe zi și fără parestezii. Proteinuria pe 24 de ore de 7,6 grame pe decilitru. Se efectuează electroforeza proteinelor, se constată o scădere a imunoglobulinilor A și gamma, deci ce sugerează o gamopatie monoclonală, cu lanțuri lambda crescute, extrem de crescute, cu un raport kappa pe lambda de 0,32 și DFLC 211 mg pe litru la baseline și imunofixare pozitivă pentru imunoglobuline lambda. Biologic, pacientul prezenta o fosfatază alcalină crescută, gamma-GT crescut, o bilirubină totală normală, o hipoalbuminemie, INR în limite normale, o creatinină serică peste 6 mg pe decilitru, uree ușor crescută, leucocitoză ușoară. Pe frotiu se constată anizocitoză moderată cu microcite oxifile, cu eritrocite în țintă și cu corp joli și eritrocite dispuse în rulouri, trombocite în limite normale, fără anemie, negativ pentru virusurile hepatitice B și C și HIV, cu un factor 10 scăzut, o feritină crescută și beta-2 microglobulină crescută. Se continuă evaluarea paraclinică, având în vedere că se ridică suspiciune înaltă de amiloidoză. Se efectuează test Schirmer, care este pozitiv, cu afectare moderat-severă de 5 mm. Se efectuează electromiogramă, fără criterii de polineuropatie, dar cu neuropatie motorie prin compresie urnară dreaptă. Se efectuează biopsie medulară, care decelează o măduvă hematogenă în limitele vârstei, cu distribuția celularității inegală, între 5-60% componentă celulară, cu prezența tuturor seriilor. Seria eritroidă era normoblastică, cu maturarea granulocitelor prezentă, cu megacardiocite cu lobulație prezervată, cu imunohistochimie, cu CD34 pozitiv în celule izolate, iar colorația pentru CD138 arată o infiltrare plasmocitară de 10% cu caracter clonal K pe lambda 1 la 10. Pacientul efectuează și evaluare gastroenterologică, se efectuează elastografie tranzitorie prin fibroschen, care decelează o rigiditate hepatică de 46,4% crescută, corespunzătoare unui scor F4 metavir, și 264 decibel pe metru, care sugerează și o steatoză, asocierea unei steatoze hepatice. La ecografie abdominală se constată un ficat cu suprafața contur regulat, dar un ficat cu hepatomegalie, cu un lob drept de 21,5 cm, aspect infiltrativ și cu două leziuni nodulare. Aici este descris o singură leziune, ilustrată în poză, hiperecogenă, care este sugestivă pentru un hemangiom hepatic. Efectuează de asemenea consult cardiologic cu ecocardiografie, care arată un sept interventricular de 10 mm, o fracție de ejecție a ventriculului stâng de 60%, fără argumente pentru o boală restrictivă cardiacă, dar cu NT-proBNP peste 17.000 picograme pe mililitru și o troponină T crescută de peste 95 de picograme pe mililitru. Se stabilește astfel diagnosticul de mielom multiplu, amiloidoză primară tip lanț ușor lambda, cu afectare sistemică, hepatică, cu colestază, hepatomegalie, rigiditate hepatică crescută, renală, cu sindrom nefrotic, cu boală renală cronică ce necesită dializă, sindrom SICA și afectare splenică, hiposplenism, corp joli și poliglobulie. Având în vedere nivelurile crescute ale NT-proBNP-ului și ale troponiei, pacientul nu este considerat pentru autotransplant. În mai 2018 se inițiază tratament cu ciclofosfamid, bortezomib și dexametazonă de linia 1. Pacientul evoluează bine din mai până în decembrie. În decembrie prezintă doar o minimă complicație, post-zona steronevralgie, care se remite, dar pacientul se menține în remisiune hematologică până în 2022, inclusiv în 2022. Pacientul este reevaluat gastroenterologic, se efectuează fibroschen, se constată o rigiditate hepatică de 52,5 kilopascali, o ușoară progresie. De asemenea, pacientul prezintă o tumefacție la nivelul hemifeței drepte, se efectuează o biopsie care ne dă diagnosticul de formațiune pseudotumorală chistică la nivelul sinusului maxilar drept, care este și excizată și rezultatul histopatologic este fără elemente de neoplazie. Efectuează și o computer tomografie whole body, care decelează două leziuni osteolitice nespecifice și un osteom osteoid la nivelul condilului femural, de asemenea nespecific. Este reevaluat cardiac, se menține septul interventricular de 10 mm, fracție de ejecție bună de 51%, dar cu o ușoară dilatare a ventriculului stâng, cu o disfuncție sistolică globală ușoară, fără semne de amiloidoză cardiacă. De data aceasta, troponina este normală, NT-proBNP-ul scade, este crescut, dar este în scădere și se instalează anuria. În aprilie 2023, pacientul se află în continuare în remisiune hematologică, se efectuează rezonanță magnetică craniană pentru descrierea leziunilor de tumefacție și pentru alte leziuni. Nu se decelează acumulări hemoragice sau leziuni ischemice acute, nu prezintă microhemoragie cerebrală, prezintă o atrofie cerebrală și se descrie o anomalie de dezvoltare venoasă versus o fistulă arteriovenoasă fină care implică vena jugulară internă și sinusul transvers drept și se menține edemul la nivelul hemifeței drepte, la nivelul țesuturilor moi. La o lună distanță efectuează și o tomografie toracică pentru suspiciune de stenoză de trunchi brachiocefalic drept, care se și confirmă cu stenoză la nivelul venei cave superioare, cu pleurezie bilaterală ușoară, cu câteva adenopatii supradiafragmatice și se descriu și modificări la nivelul parenchimului hepatic cu semiologie diferită. Motiv pentru care în septembrie 2023 se efectuează și o rezonanță magnetică abdominală care descrie o hepatomegalie difuz hemosiderotică cu leziuni hepatice cu semnal hemosiderinic, cu unele altele sugestive pentru hemangioame, dar nemodificate față de evaluările anterioare, splenomegalie, rinichi scleroatrofici și o pleurezie bilaterală. Iar în martie 2024, pacientul prezintă DFLC 172 de mg pe litru, deci în creștere, motiv pentru care se ia în considerare să se inițieze terapie de a doua linie cu daratumumab, ciclofosfamidă, bortezomib și dexametazonă. În continuare, sub această terapie, pacientul evoluează bine. La o lună distanță descrie că s-au îmbunătățit simptomele digestive, nu prezintă greață, apetitul a crescut, lobul drept era de 14 cm, fără hipotensiune arterială. În mai 2024, evoluția este în continuare bună, fără hipotensiune arterială, DFLC scad la 0,5 mg pe litru. În iulie, de asemenea, se menține în remisiune hematologică pacientul, dar prezintă un episod de infecție respiratorie cu tuse productivă, disfagie, rinoree și o proteină C reactivă crescută, iar pe spută se însămânțează streptococcus pneumonie, pentru care pacientul este inițiat pe tratament cu cefixim. Ultima evaluare a pacientului este în ianuarie acest an, când revine în clinică pentru greață, dureri abdominale, nimic deosebit pe hemogramă, o proteină C reactivă ușor crescută, o fosfatază alcalină peste limita superioară a normalului, de asemenea și gamma-GT, dar în scădere, la electroforeza proteinelor imunoglobuline A și G scăzute, cu lanțuri ușoare lambda în scădere și DFLC sub 0. Se efectuează de asemenea consult gastroenterologic, efectuează ecografie abdominală, se menține hepatomegalia cu leziunile hiperecogene descrise, cu sugestive pentru hemangioame, o ușoară splenomegalie și fără ascită, iar la evaluarea rigidității hepatice 74,3 kPa. De asemenea, efectuăm, pentru că avem disponibil, se efectuează și rigiditatea splenică de 35,1 kPa, care nu sugerează hipertensiune portală. Efectuează din nou rezonanță magnetică abdominală, care descrie o hepatomegalie cu un lob drept mărit de 25 de centimetri, cu leziunile hepatice nemodificate, ca și semiologie sau dimensiuni, sugestive pentru hemangioame, cu o splenomegalie staționară, cu mici adenopatii și minimă pleurezie bilaterală. În concluzie, ca și particularități ale cazului, aș spune că este vorba despre un pacient care a supraviețuit mai mult de 7 ani, în ciuda necesității de hemodializă și progresiei infiltratului hepatic. Absența afectării cardiace reprezintă un factor de prognostic bun pentru acest pacient. Bilirubina totală scăzută, sub 2 mg pe decilitru, de asemenea indică un prognostic bun, în ciuda progresiei afectării hepatice. Aș spune că acumularea de amiloid hepatic nu reprezintă o decompensare funcțională sau nu reprezintă același lucru și pacientul a avut o calitate a vieții acceptabilă în ciuda chimioterapiei sistemice. Mulțumesc!
Thank you very much. Thank you, Speranta. Thank you, Mihaela, for these excellent presentations. We have a lot of questions. First of questions are coming from Professor Cassi. It is regarding.
Congratulations, first of all. And I wanted to ask whether you're going to publish the data that you showed for the comparison of patients with and without liver involvement, which was defined based on which parameter? Based on the FibroScan?
Yeah,
So
not
based-
only, but,
not only, but mostly
a lot.
based- I
We
think these are
plan
very,
we
very
plan to
important
do
data.
this year because we enlarged the number of patients that we will. Yeah, we included more patients.
So you
and
do screening in every patient with
yeah.
FibroScan.
All the patients are still alive.
And we also want to
compare.
see if FibroScan is also good for monitoring of response to therapy.
Probably this will be the largest series.
I think the series is rather large for what
I
it's
think
published in literature up to now.
It's time to publish because the data in literature are very scarce, so
Yeah.
it's time to do that. I have a question for you regarding FibroScan, elastography. Did you see any relationship between volume of the spleen, volume of the liver, and the stiffness?
Not yet, because we just had this new software for spleen elastography, so we'll plan to do this now with the patients that in some we can measure the. So, in my opinion, the spleen cannot be enlarged, but the stiffness is enlarged, but not at the values that we find in portal hypertension. Usually, normal spleen stiffness is around 20 kilopascal. For diagnosing portal hypertension, the cutoffs that are in our literature for gastroenterology part is over 45 or 50 kilopascal. And we can see up to 100 kilopascal or more. In fact, the software measures up to 100 kilopascal for spleen stiffness in portal hypertension. Up to now for amyloidosis, we didn't see such high values. This is different to liver involvement, where amyloidosis in the liver leads to a stiffness that it's markedly increased up to, if we measured by share wave in one patient, I remember, because he had ascites, and when they have ascites, we can just use share wave elastography. We have also this ultrasound technique in our clinic, but we had up to 180 kilopascal. So, and this, in my opinion, it's just related to the fact that the mechanism that leads to stiffness is totally different in liver cirrhosis and amyloidosis. But for spleen, the data is really, really rather scarce, and we also for liver cirrhosis are not a lot of literature published. So I think it's, as I said, a field to research for us in the future, and I think you should help us to explain better why it's the difference in spleen also. In liver, I think in my head it's easier to explain, but for spleen, I don't know if it's the same mechanism or not. As I said, I didn't find in literature for amyloidosis any cutoffs or any one that measured the spleen besides the article with the MR elastography. And that's why we performed this last MR elastography in this patient, but the patient refused to have the contrast enhanced MR, and then our colleagues, although they can measure elastography, the radiologists, they didn't do this because the patient refused.
Just to understand, the patient refused it?
Yeah, he...
No, because we...
He tried to explain me. They changed the days of the day of the dialysis, and he was afraid because he just had the dialysis, and we want to put the contrast after dialysis, and 2 days it will be too toxic for his kidney.
So you can solve it, for sure.
So we plan to do MR elastography in this patient.
Because
this was our goal before this presentation.
7 years survival for this kind of patient is something fantastic. Status.
So, could the FibroScan help differentiate between liver amyloidosis. So the problem is this: we have many patients with refractory ascites. Right? Usually these patients also have cardiac involvement, and many of these patients also have liver involvement. And we discuss with the gastroenterologists and the cardiologists where this fluid comes from. Is it because of the liver involvement? Is it because of the right heart failure? Can you help us identify the source of this ascites, and also do you have any tricks that will help us help these patients, get rid of this refractory ascites?
With fibroscan, we cannot do, so we cannot perform fibroscan in patients with ascites, at least if they have very large quantity around the liver. If they just have in the pelvis, we can do. But as I said, we have this, I don't know if you have in the shear wave elastography that can be easy and easier performed and is also performed in patients with ascites. We also do this also for liver cirrhosis. So this can help us because, as I said, the cutoff of rigidity and stiffness is significantly higher in patients that have both liver and cardiac involvement compared just to liver or just to cardiac. And in fact, in my opinion, just cardiac involvement increase the stiffness, then followed by a higher value for liver and then even higher for both. And for treatment, this fibroscan and transit elastography cannot help, but just other management, nutrition, and as I said, albumin and everything else will help, but diuretics, yeah.
Thank you. About the case, very, very interesting case. At the diagnosis moment, he has polyglobulia, considered polycythemia. Probably a hematologist saw him for sure, and jolly body. So for sure, this patient have a spleen involvement. The stiffness was around?
It's higher compared to the normal spleen, but it's not as high, as I said.
This kind of patient should be to follow up, but now you have already 7 years from the diagnosis time. So I don't know the stiffness from the 2018.
The stiffness of the liver increased progressively.
No, I'm speaking about the spleen.
It's first time he wants to come to us in the follow-up because I don't know, the interaction with him was rather difficult. If he wants to come to us, we'll follow him with this for sure, yeah.
So this is very interesting. Patient with the spleen involvement, diagnosis polycythemia, JAK negative. If this was the diagnosis, in fact, so the hematologist should be.
I'd like to complete the first. Nobody, no physician. I'm too tired. No physician raised the suspicion of the diagnosis for amyloidosis, but the daughter of the patients who lived in US read a lot of articles, what can have my father, this and this, and send to us directly with this suspicion of amyloidosis, her daughter, his daughter.
Yes, it's very interesting because the patient lose a lot of time, but doesn't matter now. But what is very interesting also, the ratio kappa lambda. This you have to pay attention. The kappa was very high, but kappa is normal, is around 100. It's very high. And lambda was high because it's normal to be high because it's a pathogenic light chain. But in one moment, the hematologist said it's CR. Even the lambda is high. We have to explain that. Why? Because in renal kidney failure, I don't know if it's say normal, correct, but it's normal to have high kappa and lambda. This is the reason. And even in this situation, the most important thing will be the differential kappa lambda. Also, the pro-BNP.
Yeah, as I said, we were a little bit wondering if he does not really have at least subclinical involvement, or I don't know.
Yes, because
it's
no
too high.
cardiac involvement. Robert is not here anymore, but for sure they prove it. So pro-BNP is related by kidney disease, correctly?
Yes.
But so high. It's
It's
not too high.
No.
No.
Okay, thank you very much. If there are any comments, any questions?